So my name is Melanie Pickering. I work for X-Ray Associates of New Mexico, and I'm a radiologist. I did my specialty training in women's imaging, so breast imaging and pelvic imaging, both ultrasound and gynecologic imaging. So today I'm going to talk about screening mammography. There's been a lot of controversy in the news over the last probably 5 years with different recommendations about screening mammography. So that's kind of what I'm going to gear this towards, is when we should be having this done. All right, so this is just kind of a question for you guys. You can raise your hand. How often and when should a woman start having screening mammography? So A, every year starting at age 50, any takers? Every year starting at age 40? All right. Every other year starting at age 50? Every other year starting at age 40?
That's my vote. I'm sorry.
It's probably wrong. All right. So we're going to kind of go through some of these, and these are all kind of the conflicting recommendations that are out there. So in the news, 2009, the U.S. Preventive Task Force Services came out with a recommendation that women in their 40s should not undergo screening mammography, clinical breast exam, or self-breast exam. They said it wasn't necessary. That's kind of scary to me, because we see a lot of people in their 40s and sometimes even younger that have breast cancer. For ages 50 to 74, they recommended getting a mammogram every other year starting at age 50. So, and then their next recommendation was that if you were in your 40s, you only needed to be screened if you were considered high risk. One of the things that it didn't show up very well, but the vast majority of women that are in their, who develop breast cancer, 75 to 90%, have no risk factors that make them high risk. They basically have a general risk that any one of us would have, not associated with their age, how many kids they had, just general risk that they have just from being a woman. So all those people who in their 40s, 40 to 49, would not be recommended to have screening. That's where we're finding most of our cancers. So for about 50 years prior to the onset of mammography, there was no change in what the outcome or death rate was for breast cancer. When we started screening mammography in the mid-80s, we started watching that death rate decline steadily. By the 1990s, it had decreased by 30%, which is pretty successful. We haven't gotten there yet. We're not completely successful at eliminating it, but that's a huge achievement. And one of the things that was interesting was the USPSTF agreed that the benefit of screening applied to all women, even those ones in the age group 40 to 49, but that the decrease in death was higher in that age group because we were finding their cancers when they were much smaller. Instead of coming in with a 2-centimeter cancer that had metastasized to their lymph nodes or to their bone, we were finding it when it was 3 or 4 millimeters and very treatable. So that's where the death rate comes into play in a person that's in their 40s, is that we're able to treat them a lot better and quicker. So, and they did agree that screening mammography saves lives, even beginning at age 40. This is in their report. But what they looked at is they looked at all the randomized controlled trials and said, oh, well, the minimum benefit that you're going to get is 15%. When you start actually looking at the data, the benefit of screening mammography in that age group, 40 to 49, is more about 30%. So they took that lowest number that they could find in the data that's out there and said, this is what the benefit is. So what they did was, when they created this task force to look at all of these screening services that are offered to the population, they didn't include anybody that had any expertise in breast imaging or oncology. They were all primary care doctors, nothing wrong with that, but nobody that can say, hey, I know something about breast cancer, or even cervical cancer and ovarian cancer. They didn't include an oncologist to say, wait a second, we are having a benefit of doing screening starting at age 40. All right. So one of the basis for their recommendations was that screening mammography can cause many harms to women from getting screening mammography. Some of the harms that they mentioned were physical and psychological harms, having additional imaging or biopsies, overdiagnosis, and radiation exposure. So I'm going to talk a little bit about each of those. The physical harm comes from the compression that we use during breast imaging. So 1 to 77% of women will report some pain from having the exam, but they also went on to say that that would not deter them from having a mammogram. The harm that is there is from that compression. When we put the breast in compression, it's automatically released after the image is done. So it's a few seconds. It's uncomfortable, but a definitely needed part to it. The psychological harm is kind of a faulty idea that pain equals harm, that because we're having some pain, that's causing us harm. There's harms that we face every day. If you go to the dentist, it's probably going to hurt, but that's a harm that a pain that we accept because the benefit of it is that we have teeth. Getting a flu shot, it hurts temporarily. You might have some soreness, but the benefit of that is that you hope you don't get the flu. So just because there's pain that's involved in something doesn't mean that we have to avoid it. All right, so false positives. The task force submitted that screening every 2 years would result in an unnecessary loss of lives, but it would reduce that number of false positive mammograms that we have. So they admitted we're going to lose lives if we go to every other year starting at age 50, but we won't have as many false positives. The probability of a false positive exam is about 1 to 6%. So you might have one, but it's not very frequent. And then the 10-year likelihood of a false positive exam, if you're having them over the course of 10 years, is about 20 to 50%. It depends. I think most people would consider that a reasonable trade-off if 500 or more false positives resulted in one life was saved. I would take a false positive if it meant somebody else was saved. Again, so between the ages of 40 to 49, screening mammograms will have a false positive once every 10 years, on average of one. They may be called for imaging every 12 years and undergo a false positive biopsy once every 149 years. So, not too bad. All right, so overdiagnosis. This kind of comes from the idea that we find those cancers that are early on that may not have gone on to be a progressive cancer or caused a fatality because of that. And this is kind of, some of those women who you find in early DCIS, would that have gone on, progressed on to a cancer that, caused a fatality or significant morbidity. Overdiagnosis is usually at the first screening exam. That's where we find about 37% of our cases of DCIS that don't tend to progress. So, and that's a lot of times because we don't have anything to compare it to. The overdiagnosis rate, however, drops to about 4% when they start coming back annually, and we can watch the progression. All of a sudden, something goes from this size to this size. That overdiagnosis has significantly dropped. So for every 11 cancers that we diagnose by screening mammography, 2 of them are considered life-saving. 1 will be considered an overdiagnosis. So pretty good. Radiation exposure. So the task force estimated that women ages 40 to 49 were going to receive 60 milligrams of radiation over that 10-year period. The fault in that there is, and how they looked at it, was that's the dose for both breasts over the course of 10 years, not the average glandular dose for one breast. The dose is actually 3.7 milligram per exam, so that's both views for each breast. So about half of what they're saying is actually what the dose is. And what that means, what that amount of radiation accounts for, is that the radiation-induced, a fatal radiation-induced cancer caused by this amount of radiation would be 1 in 10,000. So that much radiation over that course of 10 years would cause 1 in 10,000 to have a radiation-induced cancer. And if you compare that to the chance of developing an invasive breast cancer or DCIS, it's 1 in 51 for that age group. So 1 in 10,000 for that radiation-induced cancer, or 1 in 51 for that cancer, the breast cancer. All right, so what do we as breast imagers or the American Cancer Society and the American College of Radiology recommend? we recommend starting screening mammography at age 40 every year. And that's been what the recommendations have been for a really long time. And then the task force came out in 2009 and said, oh, start at age 50 every other year. And we disagree with that. And the biggest reason is that if we were to start that group of people right now that are aged 30 to 39 with those recommendations and they were to follow those, we would lose 100,000 more women to breast cancer in that age group. So in the age group that I'm in, if I were to follow the guidelines of the task force, 100,000 people in my age group would die from breast cancer, more than what we're already seeing. That's pretty huge. Another way to look at it is how many lives we lose per year. Following those recommendations would be around 5,000 to 8,000 lives per year. So following those guidelines, I can't say that I would want my mom or my sister or my daughter to be one of those 5,000 to 8,000 per year that are lost because of that recommendation. So to me, early and tragic death from advanced breast cancer would seem a greater harm than all the harms that the task force is putting out there, that why we should go to this other recommendation. So what is screening mammography? It's an x-ray of the breast. What it does is we take 2 views of each breast, different directions, to give us coverage of as much breast tissue as we can see. Basically, you'll have 4 images, 2 of each breast. It gets read by a radiologist, someone who's been trained to interpret those, looking for things that are abnormal. Occasionally, you may need more views than that. Breast implants, they may have to take images where they displace the implant posteriorly, so that way we can see the breast tissue better, because it does limit what we can see. So, typical mammogram machine, it's very regulated, the dose that we're giving to the breast, and the standards that we have for the, how the breast is positioned and things like that. So what happens is you basically have, again, that 3.7 milligray per breast with those 2 views, all right? And that equates to about 1/10 of what your average background radiation is going to be per year. So every day that we live, every year that we're on this planet, we're exposed to background radiation. A mammogram is about 1/10 of what that background radiation is. We actually have a little bit higher radiation level than the average background radiation because we live in the mountains. The higher you are, the more radiation that you're exposed to. So if you want less, go to the coast. All right. So you have 2 plates, basically, the mammogram machine. The bottom plate is kind of a metal device where the image is actually captured. Then there's a plastic device that comes down, compresses the breast, the image is taken, the machine is released. Okay. Then they do another view where it's kind of at an angle. Same thing, compressed, it releases after it's done. And it produces a black and white image of the breast that we look at and say, look if there's anything there. All right, so what are we looking for? We're typically looking for calcifications and masses. So there's calcifications, which are little tiny calcium deposits in the breast that can be benign. They can be malignant. We're looking for those ones that are malignant. So usually your larger macro calcifications, larger calcifications are going to be benign. And then the ones that we're looking for are these micro calcifications, little tiny dots. I mean, they're little, like if you were to take a pen, little dots. That's what we're looking for. They follow typical, different characteristics, the appearance of them. So when we have a screening mammogram, we'll look for those calcifications. If we see some of those, we'll bring somebody back so we can magnify those calcifications and look at them to characterize them better. What do their margins look like? What's their distribution? And based on those characteristics, we can say, are these suspicious? Are they benign? Do we not know? And then from there, we'll say, should we biopsy it or just follow them? Or we don't need to do anything. The other thing we look for are masses. Again, they can have calcifications, they may not have calcifications, and on the mammogram, we're looking for masses on there. Those can be cancers, they can be cysts, they can be non-cancerous solid masses, fibroadenomas, and other types of tumors like that. So these masses, again, they can be cysts, which are just fluid-filled sacs, and then we can say if that's what they are, we don't need to do anything with it. They're benign. Sometimes they can be complex, have a little bit of debris or a solid component. Those get a little bit tougher to say, well, this is a benign thing, and that's when we go on to say, well, let's go ahead and figure out what it is. And then solid masses. Those ones we typically, again, some of them we can say these are probably benign, others we don't know, and then we recommend the biopsy. All right. So one of the other things that's also been in the news is breast density. One of the things that we look at and we assess on every patient is the density of a person's breast tissue. It can range from fatty to extremely dense. And the reason why we assess that is because the more dense your breast tissue is, the more difficult it is to see things. Dense breast tissue shows up as white on a mammogram, so do cancers, so do calcifications. So the more dense your breast tissue is, the wider it is on that mammogram, the harder it's going to be to pick out those masses and calcifications. So what do? It doesn't mean that you're going to be at a higher risk just because you have dense breast tissue for breast cancer. It's just a limitation of mammography. There's other options out there of what we can do to help people who have that type of breast tissue. All right, so at the bottom, 10% of women have almost entirely fatty breasts. 10% will have extremely dense breasts, and the other 80% are what we call scattered or heterogeneously dense. So kind of an example of what an entirely fatty breast will look like. So it's almost completely gray or black appearing with a few little tiny white lines where you can pretty much see through it and with a pretty high level of confidence say that there's not a cancer there. You go to scattered, you have some of the composition of the tissue itself has that fatty component. You start to get more and more fibroglandular tissue, more white, which can start to limit it. You go to a heterogeneously dense breast tissue where there's more white, and anywhere in that white you can have a cancer that we can miss. And you start to get to dense where it's almost completely white and you can't see through it very well. So what do we do for these people who have these dense breast tissue? Some of the options are screening ultrasound, looking at both breasts with ultrasound. Okay, that's what we have here to offer for patients. And basically it gives us another way to look through that dense breast tissue to find those cancers. Another option that we have is something called tomosynthesis, and that's basically kind of like 3D imaging of the breast. Instead of having those two views of the breast, one that's kind of flat like a pancake, the other obliquely, we do those same things, but we slice the breast into a bunch of little slices on the imaging. And so that we can kind of scan through it, similar to a CT scan, going through the images to look at each layer and see if we can, if there's anything there. Another thing we have is breast MRI, typically not done for breast density, but usually for people who have a high risk, carriers of the breast cancer genes. People who have greater than about 20 to 25% lifetime risk of developing cancer. All right, so what to expect? You have to undress from the waist up because we need to get to the breast tissue. Usually a robe or some sort of covering will give you to kind of sit there in. A technologist will be there. They'll position your breast in the machine. And usually there's just the two of you in the room to do this exam. Two views of each breast for a screening exam. Unless you had implants or large breasts, sometimes we have to kind of panel it to get all of the tissue. One of the things that we need to do to get a high quality mammogram is that compression. And that's the part that's uncomfortable. But that compression is what is able to let us kind of spread that tissue out to see through it the best that we can. So one of the best things that we can do is have that compression even though it's uncomfortable. So the whole thing should take about 20 minutes. You're not in compression for that long, just a few seconds for each view of each breast. Okay. So again, that discomfort is one of the things that people complain about. So there are some things that you can do. Try not to schedule your mammogram right before or during your period because your breasts are more tender during that time. Some other things, if you're going someplace for a mammogram for the first time, bring a list of the places that you've had your mammograms done before because our best friend is the mammograms before that. Okay, that's a lot of what we do is comparing the current mammogram to the ones before to look for that change, that subtle change that all of a sudden you had something that wasn't quite there, maybe a little more dense, and all of a sudden, wait a second, there's something there. Or there was one calcification and there's 5 calcifications this year. That catches, that's what we're looking for some of those things. Okay. So if you had them done bring them with you, or at least know where you have them done so we can request them to be able to compare them to. Make sure you let the technologist know if you're having any problems, so that way they can make a note and say, we're having breast pain here, or mark it on your skin, so that way I can say, oh, is there something going on there? All right. Also, medical history, what your family history is of breast cancer, ovarian cancer. They may ask you questions about when your first menstrual cycle was, when your first child was born. If you've never had children, all those things could play into what your risk for breast cancer is. Again, if you have a problem, if you're feeling a lump or a mass, it's fantastic if you can go and see your physician or nurse or somebody beforehand so they can order it as a diagnostic, so we can do the full workup instead of coming as a screening and then getting called back or having to come back again. So that's kind of a key point, is if you're having a problem, try to get it ordered as a diagnostic. All right. Again, scheduling the mammogram at a time when your breasts aren't tender or swollen, so try to avoid around your menstrual cycle. Another key thing, deodorant or antiperspirant. Don't wear it on the day of exam. Don't worry, nobody's smelling you. You're gonna be okay. What it does is it causes your deodorants and antiperspirants contain aluminum. Okay, that's how they work, is one of the process of it. That aluminum shows up on the mammogram as little tiny white specks. What are little tiny white specks for us? Calcifications. So then is this antiperspirant or is it calcification? Is this a cancer? So that's why we encourage you not to wear that. All right. And then wearing two pieces instead of wearing a dress, so you don't have to stand there completely naked, wearing pants and a shirt, so that you just have to take one off. All right. So results from your screening mammogram. So all places that are doing breast imaging are required to send you a copy of your report within 30 days in a language that you can understand. Okay. Generally, they'll be contacted within 5 working days for if there is a problem, if you're getting called back. One of the things I recommend, if you haven't heard within 10 days, contact your doctor, call us up, because we have it. I mean, I read them basically the same day. All screenings are read the same day. If for whatever reason I can't get it done that day, 8 o'clock in the morning, I've had it read and it's done. So it should be done immediately. I can't say that about every facility, but at least here, that's what I want it to be done. Okay. That's kind of enough. Let's see. All right. So if you get called back, it doesn't mean that you have breast cancer. Okay. Just because you get called back doesn't mean that that's what it is. Okay. People get called back for a lot of reasons: asymmetries, calcifications, and what it means is that we want to get a closer look at that area. I'm running out of time. So we can make sure what exactly is going on. So if there are calcifications, we're going to magnify those so we can characterize them and decide, are they benign, indeterminate, malignant? Do you need a biopsy? Same thing if there's an asymmetry. Is there something really there? Sometimes those asymmetries are just the way the tissue overlaps. So when we do those extra views, it looks like the other uterus or looks like normal tissue. We'll do the ultrasound just to give us that second look to say, is there really something there? Okay, so that's kind of our backup method to make sure we're not going to be missing anything. All right. So about only 2 to 4 screening mammograms out of every 1,000 will lead to a diagnosis of cancer. So here's some myths. All right, breast cancer only affects older women. It's false, right? Because I can tell you 2 cases before I got here of 36-year-old physicians who were diagnosed with breast cancer. A 32-year-old, 38 weeks pregnant, diagnosed with breast cancer. So it's happening in people that are younger as well. All right, so if you have a risk factor for breast cancer, you're likely to get breast cancer. Not necessarily. Okay. Breast cancer doesn't run in my family, so I won't get it. Again, 75 to 80% of cancers are sporadic, meaning that there's no family history. Okay. Only your mother's family history will affect your risk. That's also false. You look at both father and mother. Antiperspirants cause breast cancer. That's false. Okay. Birth control pills can cause breast cancer. That's also been shown that it's not the case. If I'm at high risk, there's nothing I can do about it. That's false. There's lots of supplemental screening that we can do for people that are at high risk for breast cancer. If I'm diagnosed with breast cancer, I will die from it. we have really good treatment. We're catching things early, and that's what screening mammography is for, is to catch things when they're small, and we can get it treated easy. Most breast lumps are going to be cancer. That's also false. Okay, there's a lot of things that cause lumps in our breasts that are not breast cancer. All right. If you have a biopsy, it's most certainly breast cancer. We get a lot of benign. That's because we're very cautious. We want to make sure that we're not missing anything. All right. If I'm a man, I can't get breast cancer. That's false. All right. So we have men that get breast cancer as well. All right. So what are some of the risk factors? Personal history of breast cancer. Okay, that's a big risk factor. If you've already had it, you're more likely to have a recurrence or have it again. People who have the breast cancer genes, BRCA1, BRCA2, there's a couple other ones that are not quite as common. Family history. This is kind of an important one. Your family member was diagnosed before they went into menopause, so younger. And a lot of times that's because they may be a carrier of those genes. Menopause after age 55. So the longer you menstruate, the more estrogen and things like that your body's exposed to, the higher your risk. First menstrual cycle before age 12. Again, it goes back to that length of time that you have a menstrual cycle. Never having children or having children after 30 puts you at increased risk, because during pregnancy, it stops kind of those hormones from being as fluctuant and changing our breast tissue during those times. So that's a risk factor. Race. If you're less than 40, you have a greater risk of breast cancer if you're African American. However, over age 40, if you're Caucasian, you have a higher risk. So it kind of flips there. And again, if you are concerned that you're at a higher risk, this is a conversation you can have with your doctor to see if there's additional screening tools that you may need, ultrasound, MRI, things like that. And that's it. Any questions?
I have a question. You talked about tomosynthesis. It's a diagnostic, and I have never heard of that.
It's fairly new. I mean, it's been around several years, but it's a modality that's not necessarily covered by insurance right now. And so, unfortunately, when you want it done, you have to pay a little extra to have that done. But what it is it's basically a 3D imaging tool that we have. So instead of taking those mammography images, they have where there's just two, you take a 3D object, make it a 2D image. So all that tissue overlaps. So if you have a spot here, 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 when you take that image, they all overlap, and then all of a sudden it looks like an asymmetry or a mass. And so then you have to decide, okay, is this real? Is it normal tissue that's overlapping? And so one of the things that we do with tomosynthesis is because it takes those images and slices, I can say, okay, that looks like normal tissue, this looks like normal tissue, this looks like normal tissue, this looks like normal tissue. And so when we put it all together, that's what's causing that appearance. Or you look at it, there's nothing, ugly, nothing. Then I know that it's, so it's a way for us to look and find out, is this a real finding? And then we can kind of do it the other direction too, up and down. And so it's a method for us to be able to have a better insight. And it's helpful for those people, again, who have those heterogeneously dense or extremely dense breast tissue, the ones that are really white, and we're trying to find those white cancers.
And is it available here?
We do not have tomosynthesis here right now. Santa Fe has it, so X-Ray Associates in Santa Fe has it. I'm hoping that maybe in the near future we'll be able to get a new machine that offers it here, but again, since it's not covered by insurance, sometimes it's hard to get that equipment available here. What we do have here to be able to offer kind of a similar service as tomosynthesis is the breast ultrasound. And that gives us a good idea, looking at people with breast density. Another way of looking at it, similar to the tomosynthesis. Tennessee, that's where I just came from, they actually just passed January 1st a law that requires breast ultrasound to be covered for people who have heterogeneously or extremely dense breasts. So there's different methods that we can look at those, and so those are kind of the two. So we have breast ultrasound here, we don't have tomosynthesis yet.
I have information at the table. I have a table in front of the radiology department, and I have a pamphlet there on 3D.
What's the increased radiation dose from the tomosynthesis?
I don't have the exact number off the top of my head.
Because
It's a little bit more because we're taking those extra images, But again, it's not going to be a significant amount of radiation. Having a CT scan is going to be a higher level of radiation than even having a tomosynthesis.
If you had a biopsy of your breast and then you have a screening mammogram later, do you see that on your mammogram?
So typically when we do the biopsies, we'll place a tissue marker at the site where we took that biopsy. So if you had a biopsy for calcifications or for mass, so if you had it with a stereotactic machine, a machine that uses imaging similar to mammography or ultrasound, after we take those tissue samples, we place a little marker inside, and it's about the size of a tip of a pin, so very, very small. Okay, it goes inside of your breast, and it stays there. You don't feel it, doesn't set off any alarms at the airport. You won't know that it's there. Nobody else will know that it's there. I guess you will know because you had it done, but nobody else will know that it's there. And when you have your mammograms, they're little pieces of metal, so they show up on the mammogram. And so I can say, oh, they've biopsied this area, or this part's been biopsied. And so then we can go back and say, okay, well, I wonder what it was. We can look up the pathology to say, what was it? So, and that's one of the reasons why we put that marker there, so people know that it's been biopsied. Another reason we put that marker there is that that biopsy result came back as something that needed to be removed. And it was calcifications that were a little cluster, about 3 millimeters. And I took them all out. The surgeon's not going to know where to go back to. So we put that marker there so we can target and tell them, this is where you need to go. So, they'll be there. Any other questions? Thank you.
Thank you.